Hi, my name's Otavio Barbanente, and I'm very excited to be considered for this position, the Applied Research Specialist position at the American Institute of Dental Public Health. I'm deeply committed to transforming data into action, especially when it advances equitable care for veterans and underserved communities. Thank you very much for this opportunity to share my vision and how I contribute to AIDPH's mission. So let's go ahead and get started. The publication that I chose that truly stood out to me came out together with CareQuest Institute. It was called "The Oral Health is Essential to Veteran Productivity and Well-Being," and it uses data from the National Health and Nutrition Examination Survey, or NHANES, and the Medical Expenditure Panel Survey, MEPS or MEPS, to show that veterans who experience oral pain are 13 and a half times more likely to report job difficulty. That's not just a dental issue, that's a workforce equity issue. And here's how I would build on this impactful research. First, I would set up longitudinal follow-up through some studies. I would propose expanding the study using veteran data sets like the Veteran Affairs, a Corporate Data Warehouse, or the Millennium Cohort Study, the MCS. These sources can allow us to examine the long-term relationship between oral health, chronic disease, and employment status. We would incorporate predictive analytics using R, Python, or SAS, and I would develop machine learning models such as logistic regression and random forest to find which veterans and ID which of them are most at risk for productivity loss based on their dental care history, comorbidities, and social factors. We could also visualize this geographically through Geographic Information System or GIS, as well as Tableau. We can map regions for high veteran populations and low access to dental care, especially in relation to federally qualified health centers or FQHCs, community care networks, providers, and this would help target resources when they're needed the most. And how to apply this to policy. This research could support upstream policy recommendations, such as expanding dental eligibility within the Department of Veteran Affairs or the VA, strengthening partnerships with FQHCs for integrated healthcare delivery, as well as advocating for state-level Medicaid expansion in high-need areas. Deliverables that we could produce could include an interactive dashboard, policy briefs, and a clinical integration toolkit for providers working in the veteran populations. Project-wise, I'd use the Research Electronic Data Capture, REDCap, for milestone tracking and data governance, along with some Gantt charts for maintaining timelines and assigning roles across collaborators. Now, in my experience, when I worked at the National Institute on Aging, I conducted epidemiological analyses using data from the UK Biobank, which includes over 500,000 participants. In our studies, we used about 450,000. We cut it down a little bit. Our research examined how poor oral health, specifically tooth loss, gum disease, bleeding gums, periodontitis, contributes to the onset of autoimmune diseases like rheumatoid arthritis, lupus, diabetes, type 1 diabetes mellitus, and among many others. We tested for about 40 different autoimmune diseases. And we applied disease coding using ICD-9 and 10 codes, and followed the Clinical Data Interchange Standard Consortium, the CDISC protocols. We also use Cox proportional hazard modeling and Kaplan-Meier survival curves in R and SAS to estimate the risk across age and comorbidity profiles. And we did find that individuals with poor oral health had significantly higher risk of autoimmune disease, especially those with comorbid disease or heart disease. But most importantly, we translated these results into public health recommendations, working with the NIA policy staff to adjust that oral health screenings should be integrated into routine medical wellness visits and VA chronic care programs. I also co-authored a manuscript that is now under peer review and presented the findings internally to promote whole person care for aging and veteran populations. We used REDCap to coordinate workflows, manage version control, and document tasks, as well as some things with Microsoft SharePoint as well, as we were working with a lot of different documents and spreadsheets. I also um, created some federally research briefings and presentations and annotated my code books and our scripts to support reproducibility across NIH and NIA teams. And I'd also like to highlight my work at the DC Department of Health briefly, where I led analysis on cancer screening disparities. I use electronic health record data, REDCap, SQL for some of the querying and cleaning up the data, Tableau and R for some of the visualization, as well as NVivo for some of the quantitative data analysis together with Excel to analyze all these trends and look at patient-reported barriers. And we were able to add all these insights to our annual progress report, so that that will determine how much funding that Project Wish, which is the project for screening for breast and cervical cancer, we could present so that we can continue to get funding to provide more screening for those who don't have health insurance. And we were able to help serve people that are historically underserved parts of the district, specifically Ward 7 and 8, as well as in the neighboring communities on both Maryland and Virginia. That project taught me the power of integrating qualitative insights with quantitative data to shape health equity policy. Now, AIDPH's mission to advance equity, justice, inclusion, and oral health through community-engaged research and policy perfectly aligns with my goals as a public health researcher. I'd be honored to contribute my skills in data analysis, applied research, and health equity to your incredible team. Thank you so much for your time and consideration. I look forward to hearing back from you guys soon. Thank you very much.